Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast today. My name is Terry Fletcher. So today is the last Tuesday of September, and usually I do a Top 10 Tuesday. But a topic came to my attention that I actually really like, and I wanted to talk about it and discuss it. And it was actually something I read on NAMIS, which is the National Association of Medical Auditing Specialists. And they have a blog, if you're a member, and you can really just read up on some of the things that are happening. I mean, I have a blog as well. But I thought it was interesting because there are some signs in different offices. And I've dealt with this, not just from reading what they had up there, but there's some sign in some physician offices where they talk about what you can get at their practice for cash, or if there's a no-show fee of $50 or $100. And you have to be careful because there's some compliance issues with some things like that, especially, first of all, the no-show fee. Make sure the payer allows it, especially if it's a government payer. But private payers also have their own rules about that. But what about services that are typically covered with the payer, such as maybe a B12 shot or something like that? So here's where the problem can lie. So the issue with cash payments for a covered service is that a lot of practices offer this cash payment to avoid insurance billing and then have to go chase the money down from the patient, especially patients who have high deductibles. It's hoping to reduce the administrative burden or boost revenue. However, if you charge cash for services that could be billed to a patient's insurance, this could raise some serious compliance concerns. Federal law and insurance contract language generally prohibits this practice because what it does is they believe it undermines the health payment system and can lead to regulatory violations. There's a reason things are covered or not covered. And remember, when you sign a contract with an insurance company, whether you're a provider for Medicare or a commercial plan, you agree to specific terms. And if it's a commercial plan, it's called a participation agreement. Medicare has their own agreement. And one of the obligations is to submit claims to the insurer for any, and I'm air quoting, covered services provided to patients. So if you accept a cash payment for a service that could be billed to insurance, that could violate the participation agreement. Regardless of whether the patient prefers to pay it out of pocket or not, you still may be contractually required to file a claim. And if you don't, that could mean they could cancel your contract. So you have to be very careful with that. Also, charging cash instead of billing insurance could also lead to violations under the anti-kickback statute, fraud and abuse laws, because remember, anti-kickback prohibits offering a financial incentive to get referrals for services covered by Medicare, Medicaid, and other federal programs. So letting patients bypass insurance could be viewed as an incentive, which could trigger even bigger compliance issues. Also, somebody said, what about the False Claim Act? Since, we're not billing a claim, we're just offering it cash, how could that be false claim? Well, bypassing insurance billing could violate the False Claim Act, which prohibits submitting false or fraudulent claims to the government. So skipping the insurance claim process might seem like you're avoiding those issues, but it could actually raise red flags when it looks like you're trying to dodge your legal responsibility to submit the claim. They always look at intent as well. And then, Medicare and Medicaid, going back to the federal rule, under their billing regulations, and this is under 42 U.S. Code 135W-4, see, chapter verse, where under Medicare's mandatory claim submission rule, that's what that is, providers are required to submit claims for all covered services, even if the patient wants to pay out of pocket. And it even says within there, failing to do so not only violates the rule, but you could possibly be responsible for civil or monetary penalties. So patients covered by Medicare or Medicaid cannot pay cash for services if they're seeing a participating provider. The only exception could be is when an advanced beneficiary notice or ABN is in place, which informs the patient that the service won't be covered. But without such notice, charging cash may be illegal. Now, not only that, you've got interesting record keeping and transparency issues, which I see this a lot, and this means HIPAA violations. So charging cash instead of billing insurance, I notice that sometimes the patient encounters aren't documented properly. People are like, well, it's cash, so nobody's looking at that medical record. But eventually somebody's going to say, hey, you were supposed to bill that to the insurance company, and skipping insurance billing could result in an incomplete medical record. And now with this possible transparency, you could have some HIPAA situation here, because they require that all patient encounters be documented properly. And you also have state requirements for accurate record keeping, ensuring the patient benefits from, again, their insurance coverage for any covered services. Also, remember that the OIG work plan isn't just auditing Medicare providers and Medicaid providers for what they report. They're auditing them for practices that aren't in compliance with federal laws. And one focus area is improper billing practices, such as charging cash for services that should have been billed to insurance, especially for Medicare and Medicaid patients. So you could find that you have exclusion from the federal healthcare programs, or some fines there. So, when you allow patients to pay cash instead of using their insurance, when it's a covered service, and when it's especially a federal payer, or a payer that has it in their contract language, you may not realize that you have unintended financial consequences. So insurance exists to protect patients from high medical costs, and bypassing it could result in a higher out-of-pocket expense. Or patients could lose access to follow-up care because they didn't meet their deductible, or maybe you did something that you had them pay cash for, but now there's no record of it on their insurance, and now you're trying to get a prior authorization. And believe me, I just got my certification in prior authorization, and there's all kinds of pieces to that start with what did you do first versus what are you doing now. And so it's just so important to make sure you understand your obligations when you are putting something out there, whether it be on a sign or whether it be in a flyer or something that you're trying to explain to a patient when you're charging for cash services that could be billed to an insurance. It's not just a financial decision. It could be a significant compliance risk, and it could lead to certain legal penalties, contract violations, possibly ethical concerns, and you just don't want to do that. If you want to look this up, make sure you're looking up 42 USC 132A-7BB, and also 135W-4. So 1395W-4, sorry. But this is all over the place right now in a lot of compliance conversations, and I just want to make sure that you're covered. The Codecast podcast is also brought to you today by Decision Health. Advance your coding career this November at the 2024 Advanced Specialty Coding Virtual Summits. Join top experts for cutting-edge insights in orthopedic, pain management, or anesthesia coding. Save $50 with code ASC2024 when you register now at codingbooks.com/events. So I did have a coding question today that, it's interesting because I like to share some of my coding questions that I get. And since I'm not doing a top 10 today, I'll return with that next month. There was a thread that was coming up with a Coding Corner client who shall be nameless, but the gist of it just had me a little concerned, because sometimes I'll get this where somebody on my membership doesn't like the first answer, so then they'll ask the question again but in a different way, and the answer is the same, and then they'll ask it again in another different way. I'm like, okay, I know what you're trying to goat me into, but it's not happening. So, this is what I'm going to tell you how to do it. And even though you want a different response, I can't give it to you. So the question, it came in from a coding perspective. Basically what was happening is that it's a multi-specialty group, and their APPs, which are their nurse practitioners and PAs, bill direct. They don't bill incident to, but they're receiving denials for new patient visits. And they want to charge established patients, or default to it. Let me rephrase, default to established patient visits to avoid the denial and appeal, even though the patient would be new to, they say, the subspecialty. Well, here's where you have a little bit of a problem, and I'm just going to refer to page 4 of the E&M guidelines, and it talks about using APPs or advanced practice nurses, which are your NPs or physician assistants. And on page 4, bottom of it, right column, it even says, when advanced practice nurses and physician assistants are working with physicians, they are considered as working in the exact same specialty and subspecialty as the physician, and no distinction is made between those as far as new and established patients unless it's made by the physician. So what that means is that if you are a provider, an NPP, APP, QHP, whatever you want to call yourself, somebody that can bill directly to the payer, and let's say you're a multi-specialty group and your nurse practitioner last week saw your orthopedic patient, this week is seeing a cardiology patient, you're all under one tax ID. When they move within the practice, that's the specialty they become at that time. So when they come back to a different specialty, you may have a payer saying, no, they've already been seen within the last 3 years, even though they may not have seen the physician of that specialty. So they take on that specialty because nurse practitioner and PA, their taxonomy code is generic. And AMA even said, we're not even talking about taxonomy codes. They're basically saying guilt by association. Anybody you're working with, that's your specialty. So as this question kept trying to be resaid and restated, remember, it's not about taxonomy codes. It's about who you're working with and the fact that, that was the wrong question to ask me. So basically the question is, can you bill for an established visit? Not can we default to an established visit? Well, this is an established visit. So you're actually not defaulting to anything. You're billing the new patient visit incorrect if you're part of a group that your QHPs float. So if they don't, and they're basically tied to one specialty within that practice and they don't float, then you may have an argument to try to bill for them. If the patient is coming to, let's say they were coming to the cardiology practice, never saw the cardiologist in your group or there, and they don't treat any other patients in any other specialty anywhere else, and so they were referred from an outside practice, and so they're the first one to see the patient, that would be a new patient. Now I caution you with that because doctors usually think they're referring to doctors. And so if they're not referring specifically to your physician, but your NP seeing them, your referral base is not going to be happy, especially if it's a specialty that does require some physician involvement or could require that. So keep that in mind as well. But that was kind of an interesting question that came up, and I was just like, okay, let's address that today. So my personal tidbit, yes, we did win our first football game, so I'm pretty excited on September 8th, and I'm recording in advance because I mentioned before I'm going to be traveling a little bit in September, so I need to record some things in advance. And so then the next weekend would be that you're going to hear from me would be Denver, and then the Chargers. So I'm actually a couple weeks ahead in my recording, just so you know. Also, I didn't get a chance to say this because I did record early this month. And my heart goes out to everyone from the, survivors and the families of September 11th. And I just wanted to make sure that you heard that because I would never be remiss not to remember that, since on that day, my grandmother, who was 90 at the time, was in the air, and she was on a flight from Newark, New Jersey to visit me in California. And just an interesting story, she was supposed to come out on the 10th, but she plays bingo, or did. She lived to be 100. She passed since then. But she played bingo every Sunday, and she was not going to miss her bingo game. And my uncle didn't know that. She lived with them. And so we had to last minute change her flight to that Monday morning. And it took me 4 days to get her. She was stuck in Toledo, Ohio. I had to have her driven to Detroit. It was a mess. But the happy ending is we did not lose her. And it was quite frightening because I traveled 200 days a year back then. My daughter was 6 years old, and it was a week that I was not traveling. So it was quite an interesting time and a sad time. And my heart just goes out to any family who did survive those days. So I hope, you're still healing, and we will never forget what you went through that day, not ever. So everyone, hope you have a good rest of your week, and I hope you had a good month of September, but make it a great day, and thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, Follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.